Light ne lidhe
Hello.
karen નથી.
Okay, so we have made it live on the YouTube, so we can start the meeting now. It's just getting live. Yes. Good morning, friends. Welcome back to Saturday Club morning meeting. And today we are discussing a very important topic, and that is dental care in pediatric practice. Earlier in our pediatric practice, whenever children presented with any problems related to teeth, we used to refer to dentists, but the dentist would always say that these are all primary teeth, દુધિયા દાંત છે અને બધું સારું થઈ જશે, don't worry about it. But things have changed for last decade or so, wherein pedodentistry has come to play its role. And a lot of things are happening in pediatric dentistry. And for that, we have Dr. Vinay Mulchandani as the speaker today. He is a young pedodontist practicing in Baroda for about a decade now. He is BDS, MDS, pediatric dentistry. He is associate professor at College of Dental Science. He is a certified practitioner for NITROUS, OXIDE, and dental sedation, certified for advanced aesthetic care, and he has about 7 research papers to his credit. With this introduction, I invite Dr. Vinay Mulchandani to start his presentation. Vinay, welcome and thank you.
Thank you so much, sir. Thank you for the introduction and good morning to everyone. And as you have introduced, I'll be talking about what are the changes, what has changed over the years in pediatric dentistry. So I'll share my screen now. I hope you all can see the screen.
It's not come up yet, but we'll see. It's blank. We are not able to see the screen, Vinay. It shows Vinay Mulchandani has started screen sharing. Double click to enter full screen mode. So we are not seeing the presentation.
Is it now? Is it there? Is it visible now? No.
No. Yes. There are different tabs on the menu which you have to click. You have to select from the various tabs which are open on your laptop.
Now,
What are you seeing on your screen?
my screen, I'm seeing my presentation. Given the command to share.
Somehow we are not able to see that. You can log out and do it again. We'll wait.
I'll do that. I'll do that.
We actually had a screen test sharing testing also done. Somehow something has gone wrong there. Yes, Vinay, we can see you now. You can start sharing.
Yes, I'll share the screen.
What's happening is there are many tabs open in your laptop, so you have to click on the right tab there. This what we are seeing is a Zoom. You can minimize that and look at other tabs here. This is what we are seeing is Google. Yes, now we are able to see your main screen. Yes.
Presentation now.
Yes, yes. Yeah, put it on slideshow.
So it's done on the slideshow now.
Yes, yes.
Shall I start, sir?
Yes, yes, please.
Sorry for the interruption. Good morning to everyone. And first of all, thank you for the opportunity for allowing me to speak on this topic of pediatric dentistry and what has changed over the years. So let me begin with a brief introduction about our specialty, that is pediatric dentistry. As you are already aware, it's a specialization that deals with exclusive for children. That means right from the age of infancy to adolescence, we take care of all comprehensive issues in children, including of orthodontia, and including those who require special healthcare need. For example, any child with any medical or systemic compromised condition, for example, autistic child or intellectual disability, where a normal practitioner or normal dental practitioner may not be able to handle it. We, with other behavior modification techniques, try to render the efficient treatment to the child. And the other cornerstone in our specialty is child psychology, understanding the fears and anxiety, which becomes an integral part of our practice. As Sir mentioned at the beginning, that earlier, the nature of the practice is such that a difficult child who's defiant, who's anxious and fearful, usually doesn't cooperate, and the treatment, the advice was to defer the treatment or give a provisional treatment. This has changed now because we understand the psychology. In our specialty, we are taught the psychological understanding of a child, allowing the child to express the fear, and therefore applying right behavior techniques where the child can express the fears, we modify the behavior and give a necessary treatment. And also, this, as I spoke, the behavior guidance technique starts from non-pharmacological techniques to pharmacological techniques like sedation. We employ whichever technique is necessary and give an appropriate treatment to the child. To give a preface of what has changed in our specialty, what has changed in pediatric dentistry, a couple of things like the use of nitrous oxide oxygen inhalation sedation. Nitrous oxide is always present in anesthetic field, but now the implementation has started in dentistry, more so in pediatric dentistry, in the right concentration, the right amount, and understanding the nature of the drug and how to implement on a chair side. That means while giving a local treatment to the child, especially when the child is young and fearful, we employ this sedation technique. The other change which has happened over the years is use of bioregenerative and biomimetic dental materials. Now this has changed from, there's a stark difference from earlier practice, like we all are aware about use of silver fillings, the amalgam fillings, which was called as the, which turns eventually dark in nature. So those have changed to a more biomimetic and biologically accepted fillings, which are very aesthetically pleasing, as well as they are tissue friendly. The next change which has happened is in the basic, very common root canal procedure, that is a difficult condition of a tooth, has now made possible for us, these advances have made possible for us to salvage it or to save it and make it more tissue friendly. The other change which has happened is in local anesthesia, the very common procedure which we employ in chairside techniques is use of local anesthesia in children, and this is the cornerstone for pain management. If there is effective pain management, we take a right step towards behavior management of a child. Therefore, the advanced techniques I'll be speaking about are simple changes which have been employed in local anesthesia. And the the next is talking about ceramic and zirconia dental crowns. This has been used for adult practice, but now there is an availability and implementation of the same in pediatric population. And then about orthodontics in children. Now we start earlier, the knowledge was limited with the limitation in other research applications. The orthodontic correction was started much late, but now the concept has changed. We start the orthodontic correction at a much earlier stage, utilizing the growth and development and the faster results to the child. And then lastly, I'll be talking about the radiographic advances which have occurred, the diagnostic tools, how they have changed, how things have become easier in diagnosis. Now, when we talk about pediatric practice or pediatric dental practice, these are the first images that come to mind, and this is a very common encounter for us. Fearful, afraid, apprehensive child, even a child who's defiant in nature. And in such children,
Vinay, sorry to interrupt you.
Yes.
Sorry to interrupt you, but your voice is cracking. There is some background disturbance coming. So if you are wearing any ear audio or something,
yes.
You can stop that, and without that, if you can talk.
Yes. I'll change that.
We are able to see your screen well. There is no problem. But the only thing was that audio was not good. No. Were you wearing some earphone or something, Vinay? Vinay, can you hear me? Vinay, it's okay if it's too much of a hassle to change the settings.
Yes, sir. Hello. I'll need 2 minutes to change the settings, sir.
No, it's okay. Then you continue. Continue with whatever.
Am I audible, sir, now?
Yeah, you are audible. Yes. Only thing was that there was a lot of background noise coming.
It's okay. Sir. Sorry for that, sir.
No, this is okay. You can continue, please.
Yes, sir. So, as I was talking about, these are the images which first come to the vision that defined an uncooperative patient. As sir mentioned in the beginning, that the earlier approach was to defer the treatment or maybe give a provisional treatment. But now with the advances in behavior management technique as well as in material sciences, we can give a safe chairside treatment to such a young child. Now, first, I'll be talking about the use of nitrous oxide in dental sedation. Nitrous oxide, as we are already aware, is a very mild sedative agent, which has a low potency as an anesthetic agent, but it is highly safe. So this has been employed in a conscious sedation way for child management. It is immensely beneficial in modifying the behavior on a dental chair. We need something which is safe as well as can guide the behavior in the right approach. That means taking away the fear, increasing the pain threshold. So therefore, we can use the normal dental procedures in a more effective way. It has an anxiolysis property, which is a very important property for us, that it reduces the anxiety and minimizes the fear. And lastly, it modulates the pain. It has a pain modulation property, increases the pain threshold. For example, when we're giving a local anesthesia to a child patient, most important thing is pain management. If child has any pain episode during that procedure, we take a wrong foot, and therefore the next step in behavior management becomes very difficult. But with the use of nitrous oxide in a right concentration, we give a mild sedation to the child, where child is able to take that anesthesia, local anesthesia, and the procedure thereafter becomes much easier. So that gives a positive start to the child. So these are the units, and this is the particular chairside unit which we use. It's called as nitrous oxide oxygen inhalation unit, which we use along with the dental chair. And the picture on the right shows a child which has been operated. As you can see, child is easily taking up a local anesthesia along with the nitrous oxide inhalation. Now, these are a couple of more images where the child is happy and joyant and while getting the treatment done. The same procedure, and all these procedures in a normal child may be very difficult, because the nature of treatment of giving local anesthesia and using a vibratory instruments, and which requires deep cleaning of the tissues, where a young child is definitely not equipped to cooperate. So with nitrous oxide, such patients can easily be handled. And there's a small clip which, if I can play here, which shows how a child is having the effect of nitrous oxide, a happy episode where the local anesthesia has been injected. So this entire episode of local anesthesia was completely painless for a child, and this patient is hardly 3.5 years old aged. Now, about next topic that I would talk about is the use of biomimetic and bioregenerative materials. Like these materials, the need for these materials arise because the earlier materials were not tissue friendly. They had some toxic properties which eventually we realized. So the use of silver fillings, silver amalgam fillings, which incorporates the use of mercury, were eradicated. Now these biomimetic materials are tissue biological friendly, and they have a regenerative property. They aid in growth and development of dental tissues in children. They are most important for a young child who is growing. His tissues are in a dynamic stage of growth. So we need to use something which is completely toxin free, which is regenerative in nature and biologically completely acceptable. And of course, these materials are aesthetically pleasing. They are white and tooth colored, and aid in better oral hygiene because they have better finish, polishability. So the oral hygiene, the plaque accumulation, the biofilm which forms in the oral cavity is reduced to a greater extent. Therefore, it is recommended even in children with comorbidities. Now, this is an image which shows the earlier practice as contrast to the practice in now. The silver fillings have been changed to a white biomimetic restorations. So these are, of course, besides tooth colored in nature, they are more conservative in nature. We save the tooth and tissue inside. They are more friendly for the children because it doesn't require much of drilling and cutting, and therefore these are more acceptable now and are widely used in practice. This is another example of using a bioregenerative material. There is a material called MTA, that is mineral trioxide aggregate, which we use in dentistry, which is now widely used because of its regenerative property. It has been proposed that this material can help to regenerate the bone. The lost bone in a dental infection, DENTO-ALVEOLAR infection, can be regenerated with this kind of material. It has a healing property. The tissue inside the tooth itself, the pulp, it so heals. So this is another regenerative material which is used, and it's been hardly a couple of years that this has been introduced. The next change in practice has been from use of metal caps to a white aesthetic caps. Earlier, white caps were only available for adult and pediatric patients, but now this is available for pediatric patients. And the advantage here again becomes it is more acceptable for the tissues. The gingival tissues are more adaptable on such tissues. We take out the risk of nickel toxicity and the nickel allergy, because the older restorations had an incorporation of nickel as a proportion, which in certain patients may cause allergic responses. So now with the use of white caps, that is zirconia caps and the ceramic caps in children, there is no risk of any allergic episode. They are more tissue friendly. Next, coming to the advances that have occurred in pediatric root canal treatment. Now, root canal is a very commonly employed procedure, and the need of this arises to provide a healthy and a sterile environment for a sound growth and development of the underlying tissues. There is a concept that there is another misconception that root canal should not be employed or should not be done in our pediatric patients. But this is completely wrong, as root canal treatment is done so that the tissues underneath, that is the developing tooth bud, the tissues which are developing, the bone which develops, are developing in a healthy environment. We eradicate the infection because of root canal. So it should be recommended when it is really necessary. Now, what has changed from earlier years is salvaging the difficult tooth and the difficult conditions like a severe dento-alveolar abscess, especially in children and young adults, were earlier advised right away for the extractions. We were not able to save such a tooth and condition. Today, there is a greater possibility to salvage a tooth and a tissue which is severely damaged. Availability and the use of motor-driven cleaning instruments have come in picture. Earlier, most of the root canal treatment were done with the hand instruments. Now, with motor-driven instrument, things have become more efficient and more faster. Also, there has been change in the use of medicaments. The medicaments which are used now, again, are more regenerative in nature. They are more, they have this repair property so that the gingival tissue, the periodontal tissues they heal better in a toxic-free environment. Now, these are some of the cases which I would discuss about. Like you can see the dento-alveolar abscesses in these cases. These are severe dento-alveolar abscesses which has reached to the alveolar bone. There is a draining sinus, and the picture on the right shows a palatal abscess, which in a normal condition, earlier practice were advised right away for extractions, especially in children, because these conditions were very difficult to handle. But now, as we discussed about the use of motor-driven instruments, which reach to the right depth of the tooth, we have more efficient cleaning of the infection. We eradicate the complete bacterial environment and disinfect the tooth. So the success rate, the prognosis of the tooth in such a condition has increased vastly because of these instruments. This is another case where, if you can appreciate here, there's a bone loss. There is a radicular bone loss, which was because of the abscess, the dento-alveolar abscess, which is pretty common in young patients. And this was restored and filled with a antibacterial restoration, which we commonly employ in children, so that the bone heals in a much faster way. Now, coming to the next topic that has changed over the years in pediatric practice, the use of ceramic and aesthetic crowns. As I mentioned earlier, this has been used vastly in adult patients, but this now, with the availability for pediatric patients, is another option that we can give to the patient, and again, they are far more tissue friendly. They are biologically acceptable, aesthetically far superior, greater strength to withstand masticatory stresses as compared to other restorative procedures which we use in children, because in children we need to be definite. Applying multiple procedures in a child patient is not recommended, so we need to be sure in a first approach. So we advise treatment which are long lasting and which so that the child doesn't have to go through any kind of treatment again. This is a case where a child reported with early childhood caries. This is again a common scenario in a young patient, especially in children below 6 years, because of multiple reasons like bottle feeding, to poor brushing, to any deficiencies in minerals, especially calcium and phosphate deficiencies. So these situations lead to such early involvement of dental caries. Now, these teeth were treated with root canal, and with the availability of aesthetic crowns, that is zirconia crowns, we were able to give a natural smile, which is not only helpful for the child for masticatory stresses. That means the child can eat in a normal way without the worrying of any discomfort, any sensitivity. There's a full coverage restoration, so there is no chance of reinfection, and we give enough strength to the tooth. So this has changed. This has given a major boost for young patients who demand for the right care. That means not just because these teeth will shed in a couple of years, say about 4-5 years, teeth will shed, but poor oral hygiene, bad tooth condition will affect the nutrition of the child, besides the discomfort and the other issues. So we can give such natural smile to a young patient. Again, a similar case where the child reported with early childhood caries. You can see the typical nature of early childhood caries is involvement of maxillary anteriors, which show a rapid change. There's a tooth loss, and eventually the tooth develops an pulp infection and dental abscess. So such case, again, with the use of ceramic zirconia crown, can be treated in a right manner. And earlier, the difference is the earlier such conditions were just maybe deferred, delayed, just because a couple of years these teeth were going to shed. But during that process of delay, there is a major negative effect on the permanent and the developing teeth, because eventually this infection spreads down to the alveolar bone and the surrounding environment of the tooth. The next topic that I'll talk about is the changes and the advances that have taken place in a chairside local anesthesia. Again, this is a very crucial step in pain management for child. So besides the use of nitrous oxide is one tool which we use for the pain management. But in local anesthesia per se, we use cartridge system as opposed to the conventional syringe. I'll be talking about those changes. I'll be showing the images where a cartridge system, how this is different and superior from a conventional syringe, especially for pain management. First, the difference is these cartridges come with methylparaben-free anesthetic solutions. The normal lignocaine solution, the 2% lignocaine solution which we use along with epinephrine, these cartridges are methylparaben free. The otherwise solutions, local anesthetic solutions which we use, have preservatives like metabisulfite and methylparaben. But certain children who could be allergic to paraben, and we don't know, although we take a thorough medical history, but sometimes parents are unaware, and we don't know if child is allergic to paraben, which is rare but can happen. So we eradicate that risk factor by using a cartridge which is paraben free. The other advantage with this is using a finer gauge and shorter length of needle. Now, when we give a local anesthesia to a child, the tissue penetration has some discomfort which cannot be avoided. We use topical anesthesia, we use nitrous oxide, but use of a finer gauge and a shorter needle in terms of the conventional syringe, like any disposable syringe that we use, is about 38 millimeters, whereas these cartridge systems provide us with a shorter needle of 22 mm. So the tissue penetration is appropriate for a young patient, where we don't unnecessarily go beyond the tissues, which may cause some discomfort, and also there is a risk of toxicity. Now, these are the systems, as you can see. This particular slide shows about the cartridges which are used and the varying sizes of the needles. Right from the color coding determines the different gauge as well as the length of the needle. The next slide, I'll be showing how a conventional and the contemporary system looks like. The conventional, as we all are aware, is about aspirating from the solution. Now, this solution contains methylparaben, as well as this syringe, which is about 38 millimeters and it's about 27 gauge. Whereas the picture on the right shows the cartridge system, which is paraben free and has a 22 mm short needle and 30 gauge. Now, this needle is much finer, so the tissue piercing becomes far more easier for a young patient. and the solution is aspirated in a way that the burning sensation on the tissue piercing is greatly reduced. Then talking about the radiographic diagnosis, the changes which have occurred in diagnosis, the major concern in young patients is the radiation exposure. Now, with the use of digital sensors, like RVG, this is called radiovisuography, they have a very minimal radiation exposure. The dose is very minimal, very acceptable. So earlier times, what was done was the conventional radiographs, which had higher dose of radiation, now have been switched to these digital X-rays, where the dose is very minimal. The other advancement that has taken place, the use of CBCT, that is cone beam computed tomography, which of course is a three-dimensional radiographic diagnosis and very useful tool to diagnose any pathology. And now the difference between CBCT and CT is it's a variant of CT, that is computed tomography, but CBCT has a dose equivalent of a two-dimensional radiograph. That means equivalent of a normal radiograph as compared to the computed tomography, that is CT. Also, it becomes far more economical in terms of the expenses, and also we get a three-dimensional view, which is good enough for diagnosing any pathology like a cyst or any other sinus lining or any other pathology that we deal with in a dental, or maybe a fracture, to diagnose a fracture line in a jaw. To diagnose such things, CBCT has come to a greater rescue. These are a few images where the picture on the left shows about an RVG sensor. The technique is done through a sensor. We connect it to any electronic device like a laptop or a computer, and the image is directly transported. The other advantage here is we can save the image, the resolution, the noise of radiograph is much less. We get a greater resolution. So these are, besides very low dose of radiation, which is very crucial for a young patient. And the picture on the right is three-dimensional CBCT radiography, where we get a three-dimensional slicing the multiplanar structures, where we can study where the anomaly occurs. For example, this particular image on the top left shows an impacted canine, impacted tooth, which may develop into a cyst, which may show any pathology, so which needs to be extracted or which needs to be surgically extracted. So to know the exact position, not to damage any vital tissues inside, we use such 3D techniques. Now, the next topic that I'll talk about is the advances in orthodontic technique. Orthodontic technique, in simple terms, as we refer to as braces or correction of malalignment or mal-occlusion, it's been used since years and ages. But now the implementation of this has changed by implementing this in young population. So the recognizing need and implementation of this treatment for early correction of malalignment, that is before the growth ceases. Now I'll be talking about a few patients where the implementation was done at the right age, which resulted in a great correction for a child, because before the growth ceases, before the pubertal growth, if we employ the right approach, we can change the dentofacial, besides the dental correction, we can change the dentofacial profile. And the change has occurred also in the braces system. The conventional braces have given a way to advanced braces system, which are more comfortable and they result in a faster correction. Lastly, there are something called as invisible or clear braces for patients or for people who want something which is not visible. They can correct their dental malalignment, which is not visible. So these are clear braces or invisible braces. Now, this is a case where a child about 9 years of age, 8.5, 9 years of age, came with severe malocclusion. As you can see, there's a severe malocclusion with proclined maxilla, and the patient herself, she herself wanted to get the teeth corrected because of unpleasing smile. So we employed an early correcting technique using the braces of her age. And as you can see, the difference in the incisors which has occurred within the gap of within the duration of 3 months, right? The incisors have approximated, the alignment has occurred, and I was saying she was very happy about the treatment which we delivered. This is again a patient, a young patient, where a jaw therapy, a skeletal correction was employed. As I was talking about use of these techniques in early patient before the growth ceases. And we know that a girl child and a girl patient would cease the growth much earlier. So we use a skeletal correction, skeletal and dentofacial correction using a myofunctional therapy to align the jaw, reduce the gap, reduce the proclination at the right age. And how this is done, these are a couple of methods which we employed. An orthopedic appliance like a headgear, which is an extraoral appliance for jaw growth modification. And the picture on the right is an intraoral device for jaw expansion. Now, this is used with the mechanics of opening the mid-palatine suture, and it applies slow forces, where a gradual slow forces in the right manner is applied so that we correct the maxillary deficiency. We can expand the jaw, but again, this all has to be employed or used before the growth ceases in the patient. We study the skeletal growth. Maybe it may require hand wrist radiograph or a cephalogram, where we study the residual growth which is left. And accordingly, we employ an orthopedic appliance in a young patient or a maxillary appliance where the jaw expansion is done. So to come to the conclusion, I begin with the changes which have occurred. So I would say that it has come a long way, and all credit goes to the research and innovations which have taken place in our field. Again, there is greater depth of change which can occur, but these are very vast differences which have occurred, especially in last couple of years. I would invite any questions, any queries for the presentation.
Thank you, Dr. Vinay. You may stop this.
Yes, sir. Yes, sir.
That was really very comprehensive and very crisp presentation on the recent advances, and came to know about a lot of things which we are not knowing actually. Though we refer the patients to periodontists, we actually do not know what exactly is happening. So all these technical aspects narrated in a very simple way was very a good learning point. So now the house is open for questions, comments. I see some pediatricians there, so we expect some questions from them.
Orthodontal work should be done by pediatric dentist or orthodontist?
So both, sir. It is something that because we as pediatric dentists deal children till adolescence, and we incorporate early correction. That means when we see a child in a young age, say about 12 years or 13 years of age, with a severe mal-occlusion or skeletal changes which are occurring, in such patients, we use myofunctional therapies, which we are trained for as a pediatric dentist. So it goes hand in hand. We deliver myofunctional therapies where the jaw correction. For example, if a child has a thumb sucking habit or a mouth breathing habit or any extraoral skeletal change, we give these orthopedic appliances so that the jaw correction is achieved. And later, braces can be done at a later stage of 14 years, 13 years also.
We do not many cleft lip, cleft palate surgeries at
Yes.
Children's Hospital, and
Yes,
most of them require correction later on.
Correct. Because the condition itself causes maxillary deficiency. There is premaxillary deficiency. It depends on which class of cleft lip and palate is, which class of palate is, cleft palate is involved. But invariably, these patients will require orthopedic and that is dentofacial orthopedics and orthodontic correction at a later stage. In such patients, if we use because they have a maxillary deficiency. So if we use the right appliance, right device at a young age, say about 9 years or 10 years of age, we can correct the frontal profile of these patients because they have mandibular deficiencies, premaxillary is advanced. So such patients, we can use the therapies much earlier.
So since there are no questions, Vinay, I will take.
Yes. Hello. Sorry, sir, your videos. Hello. Audio is stuck, sir. Hello.
Yeah, Vinay, can you hear
Yes,
me?
sir. Yes, sir. I can hear you now, sir.
So what I was saying that because there are no questions, we'll take the opportunity to answer some of the frequently asked questions by the parents. Like say, when do we start caring for the teeth? What age?
Right, sir. As soon as the teeth erupt, sir. In fact, we advise while the breastfeeding, we advise cleaning up the gum pads, the soft tissues, cleaning of the soft tissues. The reason for this is we avoid colonization of bacteria, sir. As soon as the teeth erupt, the colonization of bacteria, Streptococcus mutans and other odontogenic infection-causing bacteria, biofilm is generated. So we advise cleaning as soon as possible, maybe below 12 months of age.
So how do we clean?
So for these young patients, we have softer brushes with a right amount of fluoride toothpaste is used. Say, for example, gum pad cleaning, we can use any sterile cloth. And as soon as the teeth erupt, we can use finger brushes and small pediatric brushes with a right amount of fluoride toothpaste, which is in the right appropriate dose, that is 450 ppm, in contrast with adult toothpaste, which has 1000 ppm. So we use a pediatric dose of fluoride toothpaste in such patients. And if we find that child is medically compromised, or if there is any systemic condition, we include calcium phosphate dental creams, which enhance the remineralization of dental tissues. Therefore, and especially in preterm, we see many children who are preterm and premature. So such patients, majority of such children have some dental issues because of the premature nature of the development. So we introduce calcium phosphate creams, which are completely safe, even if the child, because child will be swallowing and child will be ingesting in such age. So we advise calcium phosphate creams, which are 100% safe, and they have a remineralizing effect on the early dental growth.
So do we have this special toothpaste meant for children with the popular brands?
Yes, sir. For example, yes, sir. There are a couple of brands now, and majority of pharmaceuticals have come with their pediatric range of, for example, to give some examples, like Dr. Reddy has a pediatric toothpaste called Cheerio, and similarly, Abbott has a toothpaste called Pediflor. So these major pharmaceutical companies like Abbott, Dr. Reddy's, and there are many, like even over the counter like Colgate. Colgate has come with a Colgate Junior brand. So all these have a specified formulation of 450 ppm. They can't exceed beyond that. So 450 ppm in a right amount. Say, for example, a child younger than 3 years of age, we advise a pea size, a small pea size, a pea amount of pediatric fluoride toothpaste. So even if child is ingesting, this won't have any systemic toxicity.
Right. And up to what age we use this special fluoride content?
So till the active dental growth is occurring, say for example, about 9 years to 10 years of age, at least till 9 years of age, where the active dental growth, the dental tissues are growing, we recommend pediatric use of pediatric toothpaste, especially below 6 years. Below 6 years, there's higher chance of ingesting. Child has not developed the reflexes of expectoration. So we advise below 6 years, go for pediatric only. But after that, if the child has developed reflexes, then they can switch to the regular toothpaste.
Right. Any tips on the technique of brushing your teeth?
Yes, sir. So for a young child, we advise, first of all, we advise parents to assist, or any adult or a guardian to assist in brushing, because to remove the biofilm, that is the plaque which accumulates on all the surfaces, child, of course, a young child would need assistance of the parents. But a simple technique of a circular manner is advised, which is not harsh to the gingiva, not harsh to the gums. Many parents use horizontal technique, but horizontal eventually leads damage to the gums. But we advise a soft circular motion with a soft bristle till 6 years of age. And after that, when child has more motor reflexes, child has more dexterity, then we advise angular technique, that is 45-degree angular technique, which we normally recommend for patients about 12 years and adults. So till 6 years, a soft circular technique is advised.
What about vertical strokes?
So vertical in a very young patient becomes vertical, sir, if they are not properly mastering, it may injure the gums. It may, the sulcus can be injured with that, and parents come with a complaint of bleeding gums if they are not technique right. So circular technique is gentle in nature, which doesn't cause problem, and it's easy to master for a young child.
Right. Dr. Manoj Yadav has asked a question: are motorized toothbrush better than the conventional manual ones?
Not really, sir. Not really. The manual are good enough. It all depends on the dexterity. Yes, for a child who is medically compromised, has any medical compromised condition where the motor reflexes or dexterity is compromised, there, of course, the use of motorized is highly recommended. But otherwise, it's just an additional tool. Manual brush, if you master the right technique, is good enough.
Anything to be used for interdental spaces or something like that?
Yes, sir. Yes, sir. So as the child crosses 12 years of age, when there are tight contacts between the teeth, because in young children normally there are spaces, so we advise something called as dental floss, and there is an advanced tool available now which is called water floss. Now this water floss works as a water jet, so we just press the nozzle interdentally to remove the debris and the biofilm which accumulates. Earlier, a thread kind of system, which all must be aware, was used, but this requires a lot of mastering the technique. If you do it in a wrong manner, there is injury to the gums, especially in a young patient. So now there is something called as water flosser, which it's available online. It's just a water nozzle, and you clean the interdental areas with that.
So that is advocated for all healthy, normal children also?
Yes, sir. Even for children, because this is technique friendly, it's user friendly, and even children would be very playful about it, and they can use it without injuring their tissues.
Right. So any tips on prevention of dental caries? We see a lot of even rampant caries we see in children.
Yes. So the first and foremost thing that we advise is avoid sippers and bottle feeding, the nighttime bottle feeding. That is a very basic cause for early childhood caries. And plus, if the children are introduced with fruit juices, which are citric in nature, and with something which is like packet juices, which have high concentration of sugars. So introduction of such artificial sugars is the major cause, very simple but major cause. Apart from that, the right brushing, introducing the brushing in the right age, because if the brushing is introduced at the right age, the colonization of bacteria is greatly reduced. But even after this, the child lands up in dental caries, there is a greater load of dental problem. Then we introduce something called as remineralizing agents like calcium phosphate gels, calcium phosphate tooth creams, which are prescribed once OD for at least 3 months. And apart from that, there is called as fluoride treatment, which helps to remineralize the demineralized the enamel structure of the tooth. So these are the other preventive measures which we employ. And of course, catching the dental problems at an early stage. If we see a dental problem at early stage, remove the bacterial load, automatically it adds to the prevention.
So what is the early sign of dental caries?
So early sign, first thing that we appreciate is a chalky white lines, and you see a white opacities on the dental tissues, like enamel shows white opacities. So that is the first change, that the demineralization is occurring. That means there is a calcium loss, is leaching out of calcium and minerals from the tooth, and eventually the tooth breaks down to what we see as a dental caries. The first sign is chalk white opacities.
And black pigmentation?
So that can be because of, see, there are multiple reasons for that. Can be because of the chromogenic bacteria. It could be because of supplements like iron supplements and the zinc supplements. If a child is not brushing regularly, especially after the supplements, it can eventually lead to the extrinsic stains. But if the stains are extrinsic in nature, it can be easily polished and removed. But the risk of such stains is, if child is not brushing, they catch the colonize the bacteria, which eventually leads to caries.
That
So
could
black
be a
stains
early
usually-
sign of dental caries, a blackening of
Possibly,
spots.
sir. Possibly, sir. It could be just extrinsic stains, which are just exogenous in nature. It could be food stains, chromogenic bacteria, or it could be along with dental caries. So we need to check, but yes, it has to be checked.
Any appliance for thumb sucking?
Yes, sir. So thumb sucking, we usually consider normal till 2 years of age. Post feeding, post nursing, it's usually common till 1.5 to 2 years. But beyond 2 years, if the child is involved in finger or thumb sucking, we need some intervention measures. First, we start to understand the psychological aspect of the child, and thereafter we use thumb breaking appliance, habit breaking appliance, like bluegrass appliance, which is a kind of roller blade which is fixed in the upper arch, the maxillary arch, where the child, when the is involved in the thumb sucking, is rolled away. Fingers of the thumbs are rolled away. It's kind of a reminder therapy for the child, so that the child has to stop. But this works best after 5 years of age, when child himself or herself wants to drop the habit. Below 5 years, we usually counsel the child and the parents, and around 5 years of age, we implement these habit breaking therapies.
Wonderful. That was a very good rapid fire question.
Thank you,
Most
sir.
of the questions, were very relevant, and your answers were very useful
Yes.
to the pediatric fraternity. So, any
These
more
are-
question or comment? We have a couple of minutes more if somebody wants to ask something or comment. I see a raised hand with Dr. Ambala's. I don't know whether it's accidental or he wants to ask something. Anybody wants to ask something? Okay. So thank you, Vinay, for that was very
Thank you.
wonderful, comprehensive talk and a good covering of pediatric dentistry. So thank you so
Thank you,
much.
sir. Thank you for the
joining.
opportunity.
Yes. Thank you all for joining Saturday. Next Saturday we'll meet again. Thank you all.